That was a wonderful presentation. So, hype. Professor Nat Soper, please.
Thank you very much. Can I have my first slide, please? So it's good to see a number of you want to really hear what the right answer is in this debate. And Dr. Talamini, as an academician, you know, I'm a little bit surprised at your lack of evidence basis when you're doing this. That's the wrong presentation. We need the one for Soper. And furthermore, being at a state-supported institution in the Republic of California that's flat broke, it just is astonishing that you would be speaking in favor of this expensive technology, which even you admit we have no proof that it does any good. Do we have my presentation? Thank you very much. Now, if it'll advance, it'll be really great. There we go. So these are my disclosures, none of which bear to this presentation. So are we in the era of robotic surgery, or is this era actually not going to come to fruition? Well, this kind of shows the evolution of what's happened as we've gone from semi-erect individuals and now back to sitting hunched over a console if Dr. Talamini's vision would take us to where he wants us to go. And for those who don't remember, the word robot was coined in 1920 in a play where the word robota means compulsory labor. And in fact, sometimes I feel that's what the surgeons feel like when sitting at this console. So I was asked to take the position of that robotics currently is hype. And so I thought it important to understand what that word really meant. So the definitions are given here: exaggerated publicity, or hoopla, an ingenious or questionable claim, method, etc., used in advertising, promotion, or publicity to intensify the effect, or a swindle, deception, or trick. And I mean to prove to you this afternoon that that is exactly the state of surgical robotics today. And we're not talking about R2-D2, we're talking about this computer interface between the surgeon and the patient. And I would submit that one of the main issues today is that we are in a monopoly from the Intuitive company that makes the only device that's currently approved for use for general surgery, and that is the Da Vinci. It does give you this immersive 3D and wrist. It's relatively big. Dr. Ponsky says, you know, the more of these you have, the more white coats you can hang on them. And the new SI models are not inexpensive, and compared to virtually every other area of digital information type technology over the last 10 years, this has not gotten less expensive as it's gotten increasingly complex. Over $2 million to buy the thing. It costs $800 to $2,000 per case for the instruments that you use. And then, oh, by the way, you have to hire somebody to take care of it. And this is what it looks like. We've all seen it. And it does give you this handy little wrist ornament in there. And there are many potential advantages. Even I have to admit that. You do have improved dexterity. For those of us who like a cup of Starbucks in the morning and you see the tremor magnified on the screen, this takes away the tremor with a filtering of the high-frequency movements. You can scale your motions up or down, and you get true motion of instruments as opposed to going through the fulcrum of a standard laparoscopic port, and we did mention the articulation. And I, too, agree that you have better visualization. Instead of having a third-year medical student hold my camera, you are directing it, and you do have 3D vision. And there are enhanced ergonomics for the surgeon, no question about it. And I'm really the poster child for this because I just had my second rotator cuff repair, which was thought to be due to 20 years of playing Twister on the laparoscope. And there is the possibility of telesurgery applications. No question about it. All potential advantages. We'll see if they're realized. But there are a lot of disadvantages as well. You have no haptic feedback because that is totally taken out by the computer. The expense we've talked about. There is a steep but relatively short learning curve. There's some training and safety concerns which have been partially ameliorated by the new driver's ed version with the new robot. And I would submit there are no clear indications for general or GI surgery. Currently, though, it's being used willy-nilly with a lot of hoopla and hype at many different medical centers for these various operations. Certainly, the most used indications, at least at our center, are for things down in the pelvis, such as the prostatectomy and GYN procedures. The clinical experience has been that there are lots of case series out there comparing this and that, almost no prospective randomized trials. There was a proof of concept with a so-called Lindbergh procedure done by Jacques Marescot, where he took out the gallbladder of one of his patients in Strasbourg, France, while sitting at a console in New York City. Pretty cool. My patients probably wouldn't like it very much. And Miran Anvari in Canada has actually done some very interesting things with the telesurgery and the robotics applications, expanding the field of minimally invasive surgery to remote areas of Canada. But let's get to the heart of the matter, Dr. Talamini. I mean, let's talk about value, which, as we know in medicine, is that the equation quality or outcomes divided by cost. And I think we'll look at the different, the numerator and the denominator here. So what are the quality metrics of robotic general or GI surgery? Well, there are only a handful of very small, generally poorly performed prospective randomized trials, 4 with laparoscopic Nissens, 1 with Roux-en-Y gastric bypass, 1 with a laparoscopic cholecystectomy, and 1 with adrenalectomy, that essentially had equivalent clinical outcomes of standard laparoscopy to the robotic arm. There is a question with some of these studies of whether there are fewer intraoperative perforations with a Heller myotomy, and in fact, one hyped up study was one comparing perforations in 2 different centers in 2 different continents, and the fact that there was a difference in esophageal perforation rates was thought to be incredible. But a recent study done, I believe, by Dr. Alenikoff of 2,600 patients in a UHC-based format found no difference in clinical outcomes between standard laparoscopic Heller myotomy and the robotic Heller myotomy. And not only that, the outcomes are no different really, but almost in all studies, the operative time itself is actually longer than that with the robot than that for standard laparoscopy. Well, then you say, well, it's, but the pelvic procedures, that's really where the bang is for the buck, prostates and hysterectomies and that kind of stuff. Well, there have been a couple of big studies that have been published over the last couple of years for laparoscopic assisted vaginal hysterectomy versus robotic assisted hysterectomy. There was no difference in clinical outcomes, but the OR times were longer for the robot. And another one published in JAMA a couple of years ago showed that for minimally invasive robotic prostatectomy versus standard open radical retropubic prostatectomy, the robot did give a slightly decreased length of stay and decreased rate of anastomotic stricture, but a higher rate of incontinence and erectile dysfunction for those undergoing the robotic operation. And being a male of that age, I would suggest that I would just as soon not have it done robotically. Thank you very much. So if we look at the summary of the quality proposition here, the value, the numerator being quality, I would say if anything, it's slightly less good with a robot. But let's get to the denominator. I think that's where really the heart is of the matter. How does robotic surgery affect the cost of care? Well, there are a number of studies that are out there. There was a big one published in New England Journal of Medicine now a couple of years ago that stated that the additional cost per procedure averaged anywhere from $1,500 to $3,000 with no increase in reimbursement and, quote, little evidence of improved outcomes for the use of the robot. Another one, a study done by Custieri's group, published just a couple of months ago in Surgical Endoscopy, looking at all of the robotic studies that are out there. Their conclusion was that there was a total cost for robotic surgery currently is higher than for the manual laparoscopic approach. And finally, I would say that there is no study published anywhere that has any suggestion that there's a lower cost for robotic surgery. And needless to say, in the days of Obamacare and we'll be talking about that tomorrow, my guess is that costs are a very big issue that we have to deal with. So bringing the message back home to my institution, Northwestern Memorial Hospital, they did a recent data analysis as they were considering the purchase of another robot. And what they arrived at was that the cost per case, including the capital outlay, the lifespan, and that sort of thing with the robot, as well as its efficiency of use, it ends up adding about $1,300 per case. And when they looked at prostatectomy specifically, because that's our highest use for the robot, they looked at the profitability, which includes all the hospital costs, the length of stay, and the reimbursement. The profitability for a standard open radical retropubic prostatectomy is about $3,000. Well, when you bring the robot in, the profitability goes to $1,500, but when you subtract out that $1,288 per case, the hospital makes $200 per operation. Not a very good way to make money in a hospital system. So I would suggest that the cost proposition is significantly higher, and if you put them together then, the real value of robotic surgery, of quality, a little bit less, cost a lot more, it's unjustifiable today. And what about the hoopla? Well, if you go around the country, you see billboards that look something like this, claiming things that, as I've just shown, can't be claimed really with any type of evidence behind them. So there is certainly hoopla. So I would suggest at the end and as a conclusion is that there's virtually no good evidence that robotic surgery currently improves quality of surgical care. However, there is abundant evidence that robotic surgery increases the cost of care. The value is therefore less than that of its alternative, particularly that of laparoscopic surgery for GI surgery, but even the open radical retropubic prostatectomy. And certainly much hoopla has surrounded the introduction of robots, and we look forward to competitors entering the market and perhaps changing the equation. Thank you very much.
Thank you very much, Professor Soper.